Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and these days we are talking about chronic liver disease. And in the previous video, we just discussed the common features of cirrhosis, and this time we are going to take up one of the most dreaded complications of chronic liver disease called portal hypertension and variceal bleed. It is actually the variceal bleed which makes it bad. Portal hypertension also translates into certain physical findings, but actually the variceal bleed is the one which makes it very, very serious. So we're going to cover this today. Now, some background, I think we need to understand this before we can understand the exact pathophysiology and the treatment approach to portal hypertension. You know, liver has got dual circulation. It is an organ like any other organ. It needs arterial blood for its oxygen and for its nutrition. But main function of the liver is metabolic, and it has to process the food which we ingest, and then it is converted into the proteins and fats and amino acids and other things. So this blood, 80% of the circulation of the liver comes from the portal circulation. So this is the structure or portal circulation. So as the vein coming from spleen and intestine and the lower part and the upper part of this stomach, all converging into portal vein, and this passes into the liver, and then it converts into small sinusoids and then ultimately hepatic veins. Hepatic veins then enters the inferior vena cava and then goes back to the circulation. So the important thing is this 80% of the blood has to pass through the liver, through the sinusoids, and then to the inferior vena cava. So I think it is easy to understand if there is change in the architecture of the liver, so that there is obstruction of the port flow, the pressure will build up. This normal circulation will not be possible, and then blood will be shunted out into another channel, that is I'm going to explain in the next slide. So portal circulation, this one, and the systemic circulations are normally independent. In the lower part of the esophagus, there are certain veins which drain into the azygous vein because they belong to systemic circulation. Esophagus is only a conduit. It has got no digestive function. But stomach and the intestine, they absorb nutrients. So the blood which is absorbed from the blood which drains the stomach and the duodenum, it has to go to the liver because the nutrients are to be further processed. But the blood from the lower part of the esophagus has to go to the systemic circulation because esophagus does not have any digestive function. So both these circulations, although they are connected with small vessels, but they remain independent. These small vessels here, the lower end of the esophagus, they remain like there may be very little flow but no significant flow in normal situation. There are some potential anastomosis that open up when portal pressure increases. So normally on the both sides the veins have almost similar pressure, but if there is portal hypertension, if there is obstruction to here, in some cases it may be portal vein thrombosis also, but we are going to talk about the cirrhotic portal hypertension. So if there is obstruction here, the pressure will build up. This fluid, this blood will try to find other ways, and these potential very small vessels, they will open up, and then they will carry blood from portal circulation into the systemic circulation, bypassing liver. So this in a way is nature's protective mechanism. This gives somebody some extra life, because if this was not the mechanism, then one of these portal veins will rupture immediately, and then or at least much earlier, and patient would lead to shock. So this varices, the varices are formed because of chronic portal hypertension, blood flowing from the portal circulation into the systemic circulation opening up and dilating these vessels. This results into varices. This gives additional life to the patient, but ultimately someday, some very unfortunate day, this ruptures and causes this massive GAT bleeding. So this is a little technical. We don't normally do not measure this in clinical setting, but we know that if hepatic vein portal pressure gradient is 10 or more, that is abnormal. So if it is 12 or more, that is responsible for portal hypertension. So this is the definition, but we go by clinical sign. The clinical signs of portal hypertension, ascites, splenomegaly, and on ultrasound we find dilated portal vein and we find ascites, and so all these are clinical or signs on imaging. But this is little technical, is only measured in laboratories, experimental laboratories. So there are different sites where there could be a problem that could lead to development of portal hypertension. Now, of course, you could have pre-hepatic, very uncommon condition, portal vein thrombosis. So this is actually independent of cirrhosis. Some unfortunate person can have venous thrombosis. You know, venous thrombosis can affect any vein, including portal vein. So if that is the case, it will be pre-hepatic. Now, pre-hepatic coming from the portal side. So this is pre-hepatic portal hypertension. In this case, patient would not have any signs of liver disease. It will be just portal hypertension. And then there could be post-hepatic. Liver could be normal, but just beyond liver, more toward heart, there could be obstruction to the hepatic vein, and this may cause a syndrome called Budd-Chiari syndrome. Now, excluding these two, because this is not the subject of discussion today, in our case, it is the hepatic. Now, hepatic could be pre-sinusoidal or sinusoidal or post-sinusoidal, at least technically speaking. I think in chronic liver disease, it is actually a mix. So we will actually be talking about the sinusoidal because this would cause the combined features of all these. Mostly in cirrhosis, it is the sinusoidal obstruction because of the change architecture, because of multiple regenerating nodules, because of the fibrotic tissue. All these cause distortion of sinusoids, and that leads to obstruction, and that leads to portal hypertension. Now, to further explain normal portal circulation, as I've already explained, from intestine, from spleen, and from the stomach, blood goes this way. From here, blood goes this way and into the portal circulation. After it is processed, after all the nutrients are processed, then blood goes back to the systemic circulation. And the lower end of the esophagus, and of course the rest of the esophagus, goes upward into the azygous vein. These two systems, the systemic system and the portal system, they have the communication, but these communications are normally very small and there is no significant blood flow. There may be some blood flow going this way or that way, but no definite blood flow in one direction because both are independent of each other. But in cirrhosis, if this is the cirrhotic liver, you can see the liver is coarse and shrunken, and there is obstruction to the flow. So the blood flow will continue. Some blood will still be passing through the portal system, but much of blood will be diverted into the systemic circulation through this pathway. Now, initially, these veins are very, very small, and there will be very small amount of blood flowing, but later on, as condition becomes more and more chronic, as obstruction becomes more and more, then these veins dilate and they turn into what we call esophageal varices. Now, varix is something which is a vein which is dilated, which is tortuous and has got a typical look, and that I'm going to show you. These are typically present in the lower end of the esophagus, starting from the lower end and going upward. Now, depending upon their size and to the extent to which they go, we give them different grades: grade 1, grade 2, 3, and 4 varices. And similarly, you can have varices formed in the stomach also. We call them gastric varices. Now there could be other varices like in the rectum, also in the splenic hilum, in the peritoneum. So there are many places where there could be collaterals, and we know this because of its association with upper GA bleeding. Occasionally, patient may bleed from other varices, and sometimes patient comes with shock and bleeding. We are unable to find out the exact site of bleeding, so there could be bleeding from one of these collaterals. Now, factors are responsible for variceal rupture, because patient with chronic liver disease has varices. Almost all of them they have, unless somebody has the relatively early cirrhosis. But all those patients who have moderate to advanced disease, they have varices. And when we do endoscopy, we find them. But many of them, they do not rupture. There are certain factors which can lead to rupture, so it's important to identify those factors, because if they're controlled, then maybe we can prevent rupture. First of all, I think most important is the hydrostatic pressure in the portal system. Greater the obstruction in the liver, greater the cirrhosis process, greater the obstruction, and higher the pressure. So I think most important factor which can lead to the rupture is hydrostatic pressure in the portal veins. Then infections. Now this we have seen that there is some correlation with some systemic infection and rupture of portal system, now portal veins, the varices. Maybe because of the infection there is increased blood flow, or maybe because some enzymes are secreted, the veins become more friable, but there is different association between infection and variceal bleed if you already have varices. Non-steroidal anti-inflammatory drugs are known to cause gastric erosions and ulcers. If somebody is a case of cirrhosis, that person is particularly prone to have NSAID related gastric complication, because the pressure in the gastric veins, the capillary, is already high, and if somebody takes non-steroidal anti-inflammatory drugs, there could be ulceration, erosion, and these may be responsible for variceal bleed. Now let me explain to you. A young doctor is always trying to find the cause, to differentiate between ulcer related bleeding or liver diseases related bleeding. So if somebody gives a clear-cut history of non-steroidal anti-inflammatory drug, otherwise asymptomatic, and if that person comes with bleeding, I think even in that case, you need to rule out background liver disease and variceal bleeding. Because patients with varices, they become more vulnerable to the bad effects of non-steroidal anti-inflammatory drug. Since liver disease is common in our country, and since there could be a liver disease which is not clinically evident, so I think some kind of investigation should be done. I believe all patients with upper GA bleed, whether or not due to NSAID intake, should have endoscopy. So that gives you a clear picture if there is varices. So background liver disease and coagulopathy, the same level of hydrostatic pressure. Somebody with advanced hepatocellular dysfunction is likely to have low clotting factors, and also likely to have prolonged prothrombin time and prolonged INR. So person with liver disease, portal hypertension, and coagulopathy is more likely to have bleeding. Patient with chronic liver disease also have thrombocytopenia. So if there is a thrombocytopenia, that of course also can contribute to GA bleeding. So background platelet count. So this was, now let me talk about various types of gastrointestinal bleeding. Arbitrarily, we define it as upper GA bleeding, abbreviated as UGIB, upper gastrointestinal bleeding, or lower gastrointestinal bleeding. And which is the cut point? There is a, I think, end of the duodenum, and this area is marked by a ligament they call ligament of Treitz. Ligament of Treitz has got nothing to do with the bleeding, but it just indicates the anatomical landmark. Above that is upper gastrointestinal tract, and below that is the lower gastrointestinal tract. Why it is important to differentiate? Because in the upper part of the gastrointestinal tract there is acid. This acid is likely to alter the blood, and the blood, you can tell from the very look of the blood that this is from the upper GI tract. Now, there are two types of upper gastrointestinal tract. One is hematemesis, that means vomiting of fresh blood or vomiting of coffee ground blood. Why it becomes coffee ground? Because once blood stays in the stomach for some time, in the presence of stomach acid, gastric acid, it turns brownish color. Okay, so that is coffee ground. If somebody has bleeding and have immediately vomiting of blood, that would be fresh. And if there is large amount of blood, that again is likely to be fresh, because large amount of blood cannot be altered by the acid. But if it's relatively small amount and if it stays in the stomach for some time, it is likely to be coffee ground. Now, melena is passage of black tarry stool per rectum. Now, please note down, if somebody has melena is black tarry stool in the black tarry stool passed through the rectum. Now, if that is the case, that is also classified as upper GA bleeding. Although it is coming from the lower gut, but the site of bleeding must be upper part, only then it could be altered, because black tarry means it is altered by the acid. You need to have a significant stay of blood in the intestine with acid to become tarry. If somebody does not have black tarry stool, it does not rule out a GI bleeding, but presence of it will confirm it. In lower GIT bleeding, it could be hematochezia. Hematochezia means passage of fresh blood per rectum, and the problem is in the sigmoid colon or in the colon in the form of diverticulosis or some arteriovenous malformation, and I think hematochezia is if you have bleeding from the hemorrhoids, that is called simply rectal bleeding. Hematochezia means blood which is passed in to the rectum, which is fresh. You can identify, even the layperson can identify that this is blood, but it is coming from the rectum. And then the occult blood loss. Somebody may develop anemia over time, whereas you don't see any blood, and the stool is not black or tarry because it is a small amount and it is passed over time, and that becomes responsible for anemia, but there is no actual blood loss. Now, occasionally this hematochezia could be sign of upper GI bleeding also. Now, this will happen when there is large amount of bleeding from the stomach or the duodenum, but the transit time is short. Blood very rapidly passes through the small intestine. Only if it is large amount, particularly if patient is on acid lowering therapy, patient has a state of achlorhydria, or patient is on large doses of proton pump inhibitors or other drugs, so then I think it could be hematochezia. But you can identify such patient because this kind of patient is likely to be hemodynamically very, very unstable, because you need large amount of blood going through the intestine to become hematochezia. So this was the types of bleeding, and now I think I'm going to talk about the etiology. In the presentation is, of course, first of all, hematemesis and melena. Hematemesis or melena could be both present, or it could be just hematemesis, or could be just melena. And I think history will tell you. Pallor, remember, whenever there is acute gastrointestinal blood loss, there may be a time when there may not be any clinical signs of pallor, and patient may not actually develop drop in HB also. Because when we lose blood, we also lose proportional amount of plasma and RBCs both. So there may not be pallor only when there is massive bleeding, or only one some time has passed, there could be pallor. Although patients with chronic liver disease are likely to be pale because they are chronically anemic, but the presence of pallor would indicate the blood loss. Hypotension, every patient with GA bleed may not have drop in blood pressure, but those who have significant blood loss, they are likely to have low blood pressure. Blood pressure could be very low and patient may be actually in shock. That means circulation is compromised and blood pressure is less than 90 and patient has got other organ involvement of the brain, involvement of heart, involvement of kidneys, and involvement of peripheral circulation. And then stigmata of cirrhosis. Now please note down, we are discussing variceal bleeding. I'm not covering other types of bleeding. So in this context, if patient has got background liver disease, you should be able to identify some of the stigmata of chronic liver disease like ascites or telangiectasia or spiderangiomas or palmar erythema. So I think you should, if the patient is not a known case, you should quickly examine the patient for these stigmata. If patient has one of them or multiple of them, then you should immediately start the treatment, which is specially tailored to variceal bleeding. Encephalopathy, because patients with upper GA bleeding are likely to go into hepatic encephalopathy. Now this I will cover in a separate video, but very briefly, why patients with upper GA bleed, they tend to develop hepatic encephalopathy for two reasons. There may be more than two, but actually I'm going to just highlight two reasons. One is that because of rupture of portal veins, there is sudden drop in portal pressure. Sudden drop in portal pressure will further reduce the blood passing through the liver and liver circulation will be compromised. Liver is already under additional burden, but the circulation is compromised, so the liver function can go further down and that could precipitate hepatic encephalopathy. The other factor which is better known, that is the large amount of blood in the stomach acts as a protein meal. You know, protein meals can also precipitate hepatic encephalopathy. So since large amount of blood in the stomach, that acts like a protein meal, and this blood is actually low biological value protein, and that leads to ammonia formation. So these two factors can precipitate hepatic encephalopathy. Upper GA bleeding is already a serious condition. If hepatic encephalopathy is added, then it becomes even more serious. So our attempt is to prevent hepatic encephalopathy. How do we do that? I'm going to explain in the subsequent slides. Differential diagnosis, peptic ulcer. I think in the books you will find the commonest cause of upper GA bleeding is peptic ulcer, but I really doubt that statement, because I think that may be true in the past, but now we have such effective treatment for peptic ulcer, including H. pylori. So I think peptic ulcer hardly ever bleed these days. These days, the commonest cause with upper GA bleed, in my opinion, is variceal bleed, especially if somebody has any stigmata of chronic liver disease. Erosive gastritis, somebody taking a non-steroidal anti-inflammatory drugs or some other drugs which could have this erosive effect, or maybe binge of alcohol or some other corrosive drug that could cause erosive gastritis. So that may be another cause of massive GA bleeding. Mallory-Weiss syndrome is a condition where there is linear tear in the lower end of the esophagus. This results from a severe bout of vomiting, and typically historically related to alcoholic intake, binge, but I think anybody who has any severe vomiting due to any cause could have this Mallory-Weiss syndrome. Then there could be actually the rupture of esophagus also in severe cases, Boerhaave's disease. So I think that will be extreme. Then vascular abnormalities. Now this is just to give you a complete picture. I'm basically focusing on variceal bleed. It is possible that somebody with chronic liver disease, with established disease, has come with upper GA bleeding, but the cause of bleeding may not be varices. That is possible. So that is why we need to consider these conditions. Vascular abnormalities, congenital ones, very difficult to diagnose because often these are small tufts of vessel which are hidden in the stomach rugi and not easy to identify. There may be many others. Actually, I cannot complete the list because of the time constraint. So there's a long list of causes. Approach and management. This, of course, is very, very important. I think if you have understood the background, you will understand this very easily. First of all, of course, you need a quick history and examination. Now, I need not emphasize that this is a kind of emergency. You will take a quick and targeted history. You will focus on the GI bleeding and you will try to make an assessment how much blood has been lost, and if the patient has chronic liver disease, and if the patient has ingested something which could be responsible for GI bleeding. And you will not, of course, go into the detailed family history, past history, because time is extremely crucial. Once you provide initial management, then of course you can complete the history. Then again, quick physical examination, primarily focused on hemodynamics. You will measure the blood pressure, you will measure the pulse, you will measure pulse oximetry, and then look at the chest if patient has aspirated something, and of course mental status. So I think this will provide the quick history and examination, and you will immediately know how serious the patient is. In all patients who have bleeding and those patients who are serious, anybody coming to the emergency, it is the standard practice to secure an IV line. Now, since in this patient we might have to give multiple things intravenously, we prefer to take double IV line. And before patient collapses further, it is a good strategy to secure double IV line so that all the drugs and blood transfusion can be given through this. And blood should be drawn for CBC because we need to know the HB level, and we also need to do routine laboratory tests, and we also need to do the blood grouping and cross matching. So I think all this should be done in the initial assessment, and this will help you. Of course, I told you initially CBC might not show the drop in HB, but you will repeat it and then you will know the exact picture. But if somebody has already dropped in HB, then of course the condition is very serious. Now, the first line of treatment, actually everything is done in parallel. It's hard to tell which one is the first thing to be done. IV fluids should be started to keep this IV line open, and a nasogastric intubation is also the standard procedure. I'd like to explain why it is required. Number one, it would be a confirmation. If you pass an NG tube and if you can take out some blood from the stomach, it will confirm that this is actually the upper GA bleeding. The blood is coming from the stomach and not from the lungs or anywhere else. Number two, if you keep the tube in, by repeated suction, you will know the bleeding has stopped or not. I think most important thing why we want to pass the NG tube is that we want to remove the blood in the stomach. It is important because the presence of blood in the stomach is likely to precipitate hepatic encephalopathy. So this blood which is present in the stomach needs to be taken out by NG tube and by passing some saline and literally washing the stomach. Then blood transfusion. A youngster might think that everybody with upper GA bleed should be treated with blood transfusion. That is not the case actually. It has been seen that giving too much blood and IV fluids can increase bleeding, which is simple to understand because once there is bleeding, portal pressure drops. So the drop in portal pressure that helps in stopping the portal bleeding, the variceal bleeding. And if you give too much IV fluid and if you give too much blood transfusion, that might increase the portal pressure again, and that might lead to recurrence of bleeding. So there is a threshold. Previously, this threshold was 9 gram. If somebody had 9 gram hemoglobin, that was a candidate for blood transfusion. Now we know that even 9 gram is safe. So I think 7 is the current standard. If somebody has 7 gram of hemoglobin, that person needs to be given blood transfusion. If somebody has 8 gram, 9 gram, and especially if that person is hemodynamically stable, I think it is best to arrange blood transfusion but not give it and secure hemostasis. And once a definitive treatment of variceal bleeding is done, then maybe if needed, blood transfusion can be given if needed, of course. At the same time, in parallel, we try to stop bleeding. And the initial treatment of choice is pharmacological control. Of course, there is endoscopic way also. I will discuss the pros and cons of endoscopic way of controlling bleeding, but pharmacological control of bleeding is the standard way of treating. What is it? It will be explained in the next slide. Treatment algorithm in variceal bleeding. First of all, we have two vasoactive agents. One is octreotide and the other one is terlipressin. Terlipressin is actually a derivative of vasopressin, and that came into the market later. Octreotide is derivative of somatostatin, and this actually regulates our somatostatin, regulates our splanchnic circulation normally. If you give octreotide, it is expected to cause splanchnic vasoconstriction. Now you heard it right. It is not vasodilatation. It is going to cause the vasoconstriction of feeding vessels into the splanchnic bed. So once there is constriction of these arterioles, the blood going into the portal circulation will be reduced and portal pressure will reduce. So this is how it works. The first bolus dose is given 0.5 mcg intravenous. One ampule has 0.5 mcg. So, and one box is like 5 ampules. I think this is the practical point. If you have this drug, we will one box will have 5 ampules. One of them can be given intravenously as bolus, and the remaining 4 can be diluted to give an infusion. Like, we have to maintain it. One ampule is going to cause some immediate benefits, but it is not going to last. So we have to give it in the maintenance 0.5 mcg per hour for 3 to 5 days. The remaining 4 ampules may be diluted in 100 ml of saline, and that given, and the rate is set approximately to give it like 0.5 mcg per hour, and it is continued for 3 to 5 days. Now, point I would like to make here is patient would probably be controlled in maybe 12 hours, 24 hours, but infusion is still continued. Why so? Because once the variceal bleeding stop, we still want to keep portal pressure at a relatively low level by keeping splanchnic vessels constricted, by keeping portal pressure low, so that there is complete healing. The clot is formed. Clot is formed in the portal, the variceal varices, and there is no immediate recurrence of bleeding. And this would be particularly true if you are unable to offer a more definitive treatment like banding. So I think this is important. Then endoscopic treatment should be offered. Practically speaking, if you have the facility, everybody who has variceal bleeding, even if you are able to control it with this pharmacological therapy, should have endoscopic assessment. Now, endoscopic assessment will surely tell you if the cause of bleeding is varices and if there is any chances of further bleeding, and I think it will also provide the opportunity to do the therapeutic ligation. Now, there are two types of things which can be done. Of course, this is beyond the scope of our lecture. There could be endoscopic variceal band ligation. In a picture, I'll show you what it means, or injection sclerotherapy. In the past, this used to the standard treatment a sclerosing agent like absolute alcohol or sodium moreuate or sodium tetradecoate. So those are the substances which are injected into the varices or around the varices that would lead to the sclerosis, inflammation, and then followed by fibrosis and closure of these vessels. This was relatively a painful experience for the patient, and I think nowadays, since this endoscopic variceal band ligation is possible, This is definitely better because it is less painful for the patient and more definitive way of stopping bleeding. But still, if the facility for banding is not available, then sclerotherapy can be offered to save life. Now, sodium tetradecyl sulfate, this is a substance which is used for the sclerotherapy of gastric varices. Little expensive, not easy to find. I think we need to, as I told you, there are two options in pharmacological. Which of the two pharmacological intervention is better? There is often debate. I believe both are acceptable. Octreotide versus terlipressin. Octreotide is given as IV bolus and it must be continued as IV infusion. And we have more experience with octreotide because it has been available for much longer time and we feel more comfortable. So I consider octreotide as drug of choice. But terlipressin has some advantages. It can be given as IV boluses. Now, if patient is less serious and you do not have proper intensive care setting, maybe this has the attraction that you give intravenously every 6 hours. You give an intravenous bolus, and one study has shown that it reduces mortality in hepatorenal syndrome, whereas octreotide has not demonstrated this. But how much importance will I give to this? I'm not sure because this is not a common complication. ECG monitoring is needed. It is because this is actually a vasoactive substance. Occasionally, if somebody has background coronary artery disease, it can precipitate arrhythmias and coronary vasoconstriction. So ECG monitoring is needed. So I think both are acceptable, but as I said earlier, in our setting, octreotide is preferred. Now this is what the varices are. You can see this is an endoscopic appearance. The scope is on this side, and on the other end you see the esophagogastric junction. These are the different columns. There's one column, another one, and this is called red veil sign. Now this patient, this point is at the verge of rupture. So this is also another red veil sign. So on the endoscopic assessment, if you have large varices, especially if there are a red veil sign, even if patient is not bleeding, then you need to do something, either banding or sclerotherapy, because this would indicate imminent bleeding. So these are the varices. I think these are probably grade 4 because they're fairly big. In therapeutic endoscopy, urgent versus elective. Now, what do you think? If you are sitting in the emergency and you receive a patient with variceal bleeding and you have the facility of endoscopy, what do you think? Is it better to do urgent endoscopy? I'm not sure. Actually, you could make a case because this would be a definitive way of securing bleeding and ligating vessels. But doing endoscopy in a patient who is active bleeding is not easy. Patient is very unstable and there is a lot of blood in the stomach and you might not feel the clear field. So I think urgent endoscopy has got pros and cons if available and somebody can try it. Elective means I think I would recommend controlling bleeding with pharmacological therapy, octreotide, and removing extra blood from the stomach by NG tube, and maybe 12 hours or 24 hours, within 24 hours, an elective endoscopy should be done. By that time, I think the full team would be available and in a better, more comfortable environment, elective endoscopy may be done. And even if patient has now stopped bleeding, this variceal banding would actually make sure that it doesn't bleed again. At least the chances will be reduced. So in my opinion, all patients coming to the emergency should be treated with pharmacological therapy and they should be prepared for elective endoscopy the next working day. Right? So I think this is a good compromise. Both are done. Now, which one is it, banding or sclerotherapy? Banding is clearly better, but if banding is not available, sclerotherapy may be life-saving. It is to be done on multiple times. One round of banding or sclerotherapy is not enough. Typically, patient is sent home and patient is called back after 2 weeks for review. And the gastroenterologist will do a repeat endoscopy and see if there is any point which needs to be banned or which needs to be sclerotherapy, which needs to be injected. So, and usually 4 times sessions are needed. You can never cure these varices. You can actually control them and you can control bleeding. Please note down, doing banding and sclerotherapy means that the portal pressure is increasing because you are actually blocking one way of going blood to the systemic circulation. So it is a compromise. It's not a definitive treatment. Now this is the various types. This is the varices, esophageal varices. These are the one when they dilate becomes varices and through endoscope, and this is banding. They suck the tuft into the endoscope and then put a band. It's like just like ponytail. Now then blood which is held in here will clot and then this will be fibrosed. This one also like this. And this is injection sclerotherapy. A cannula comes out and there's a needle you can see, and you can inject sclerosing agent into the vein and also around vein. So these two are different therapies, ligation and sclerotherapy. So we are coming towards the end of this presentation. Please bear with me. Prevention of rebleeding. Once you have controlled bleeding in the emergency setting, then you need to give medication to prevent recurrent bleeding. Non-selective beta blockers like propranolol or carvedilol. Carvedilol has got additional alpha effect, but its beta effect is non-selective. Why do we want non-selective? Because selective beta blockers, they have effect only on the coronaries or heart, whereas we want effect in the systemic circulation. So in this situation, non-selective beta blockers are better, at least theoretically so. So we give propranolol or carvedilol, not the selective beta blocker. Those who do not tolerate these beta blockers or those who do not get the desired effect due to these beta blockers, we can add nitrates. Now remember one thing, beta blockers and nitrates, they can cause hypotension, and patient with chronic liver disease with the recent GA bleed is already likely to have hypotension. So that becomes a limitation. So sometimes we are unable to give the full therapeutic recommended dose of these drugs. Then there's something called TIPS that can be done. This can be done as an emergency procedure if the setting is allowed, or it can be done later on, those patients who do not respond to this one. What is TIPS? I'm going to show you in the next slide. And then also peripheral portosystemic shunt. These are, I think, I'm going to explain in that subsequent slide. Let's first talk about TIPS. TIPS is transjugular intrahepatic portosystemic shunt. I think if you read this word slowly and try to decipher, you can find out transjugular means catheter is passed through the jugular vein right into the hepatic vein. Okay, so this is branch of hepatic vein. From what goes to the here. And then intrahepatic, this shunt is within the liver. And portosystemic, this is the portal vein, and this hepatic vein in this part of systemic. So a communication is created between portal vein and the hepatic vein. And this is of course a very, very advanced procedure. I think two doctors, one passes through this one and the other one this one, and then with fluoroscopic technique they somehow place this shunt, And what is the advantage of TIPS over conventional portosystemic shunts? That this is externally adjustable. Now, one of the problems with portosystemic shunt is that there may be too much shunting. And I'll explain to you in the next slide. There may be too much shunting, and that may precipitate hepatic encephalopathy. Since this can be regulated from externally, and once you see that the desired drop in portal pressure has been achieved, not too much, not too little, then you take out the catheter and this then remains in place. So what it does is, within the liver, it will allow some blood from the portal circulation to go into the hepatic vein. Of course, it is through the liver, but in a way, practically speaking, it is functionally speaking, it is bypassing the liver because it is not passing through the sinusoid. This blood is not detoxicated. It will have all the toxins with it, and so this is like bypassing liver, although this shunt is within the liver. Conventionally, this is relatively advanced technique. Conventionally, there was another procedure called portosystemic shunts. Now, what is portosystemic shunt? A shunt between any of the branches of the portal venous system and any of the branches of the systemic venous system. And you would find, of course, it possible only in the abdomen, right? And major surgery with sufficient significant mortality because patient is already very sick and you have to go retroperitoneal. So I'm not a surgeon, but I know it's a long surgery. You may need 5-6 hours to get to the side where operation is to be done. And then blood will be shunted to systemic circulation. Now, if you make a big shunt, large amount of blood will be shunted from portal to the systemic because the portal pressure is high, systemic pressure is low. In patient with CLD, very large amount of blood will find it easy to go to the systemic circulation. So that will bypass the liver and that will lead to drop in portal pressure, but then it could also precipitate portosystemic encephalopathy. It could precipitate hepatic encephalopathy, also called portosystemic. The name indicates that this encephalopathy is because the portal blood goes to the systemic circulation bypassing liver. So all the toxin can go to the systemic circulation. So an ideal person for this procedure would be the person who has very high portal pressure, is not responding to medical treatment and is reasonably fit to undergo this big surgery, and there is no significant residual encephalopathy. That I think is not easy to find. This kind of patient is not easy to find. So once a shunt is created, there is a chance of later thrombosis. Now let me just expose this various types of shunt. I'm not going to tell you the details. So these are various types of shunts. So like what this one is perhaps the most popular and easy to understand. This is splenic vein, which is a branch of a part of portal system, and this is renal vein, and anatomically they are close to each other. On the left side, a shunt is created here. So the pressure from the portal vein will be shunted to the splenic vein. But all the downsides also I have explained to you. The prognosis, this is of course a serious condition. It has got high chances of mortality and morbidity. It depends on the amount of blood loss. Of course, the more blood loss would mean poor prognosis. The presence of coagulopathy, presence of Bragg-Green liver, how advanced is the liver disease. Sometimes even small varices can rupture because of an additional factor. They carry a better prognosis. Those who have child class C disease, severe thrombocytopenia and prolonged PT, prolonged INR with background liver disease, they are more likely to have profuse bleeding. And portal pressure is also one of the determinant, and then the care provider. Of course, the care provider will also determine the prognosis. So prognosis on the whole remains poor, although a lot of things can be done, and I think we still be able to save about 70 to 80% of the patient with variceal bleeding, but some 20% they die. Now, summary. First of all, variceal bleed is the most dreaded complication of cirrhosis. There are many other serious complications, but variceal bleed is the most dreaded. Number one, it is the serious in itself. Number two, it can be followed by hepatic encephalopathy, another serious complication. Quick assessment and pharmacotherapy with octreotide is needed to save life. Terlipressin is acceptable alternative, and emergency endoscopic procedure is also an option if possible. Timely endoscopic intervention and endoscopic variceal band ligation should be performed, in my opinion, after the patient is stabilized, bleeding has stopped, and in a more definite way and a proper setting. I think within the first 24 hours, all patients with variceal bleed should have an endoscopic evaluation and endoscopic variceal band ligation. Despite multiple treatment options, the long-term prognosis remain guarded. Why? Because we do not have cure. Patients with chronic liver disease, they may need transplant, but when we talk about the portal hypertension, I think endoscopic variceal band ligation is perhaps the best thing we can do. So with that, I'd like to thank you. This is Professor Aziz-ur-Rehman from Medurstand. This was one of the lectures regarding liver diseases, and I'm really looking forward to see you in the next lecture, which is again related to one of the components of chronic liver disease. Thank you very much for your joining this channel. Thank you.